I'm Dr. Laura Zemini. I'm one of the endocrinologists at Beth Israel Deaconess Medical Center and Harvard Medical School. And today I will be talking about the pathophysiology of adrenal disorders. I have no financial disclosures. And the learning objectives of this talk are first to evaluate and follow up adrenal incidentalomas. Secondly, to understand the clinical presentation and evaluate for primary hyperaldosteronism, Cushing syndrome, and pheochromocytoma. And lastly, how to diagnose and treat adrenal insufficiency. So the talk will be divided into those three sections. So as a review and introduction, the adrenal gland consists of the adrenal cortex and the adrenal medulla. The adrenal cortex is derived from mesenchymal cells, and it contains the outer glomerulosa, which makes aldosterone, the intermedia fasciculata, which makes cortisol, and the inner reticularis, which makes androgens. The adrenal medulla is derived from neuroectodermal cells, and that produces catecholamines. So the first part, we'll be reviewing and talking about adrenal incidentalomas. So an adrenal incidentaloma is found during radiologic examination, which is performed for a reason that's actually not related to the adrenal gland. So it excludes patients who are undergoing imaging procedures for part of staging of workup for cancer. The prevalence does significantly increase with age for adrenal incidentalomas. So for example, the prevalence is less than 1% for patients under 30, but it can be up to 70% for patients over 70 years of age. And I wanted to just give a clinical presentation of a patient who potentially could be in your clinic. For example, a 64-year-old woman who had unspecified abdominal pain. Her past medical history includes prediabetes and hypertension. The medications she's taking include omeprazole and lisinopril. Her family history is negative for adrenal disease. On review of systems, it's only positive for occasional palpitation. Her blood pressure, her physical exam is notable for a mildly elevated blood pressure of 136/76, normal pulse, slightly elevated BMI of 27.7, and she has an unremarkable physical exam. She does not appear Cushingoid on her physical exam. Her blood tests, the electrolytes are normal creatinine is 0.7, and A1C is in the prediabetes range at 6.1%. Imaging, because of her abdominal discomfort, was notable for no acute intra-abdominal process. However, it did show a 13 millimeter left adrenal adenoma. So then the question comes up, what additional lab evaluation would you do in this patient at this time? And I have the 5 different potential options. A, no further testing. B, testing for Cushing's. C, testing for hyperaldosteronism. D, testing for pheochromocytoma. And E, all of the B, C, and D. So the answer to this is B, C, and D, and I will go through and explain this in the next few slides and throughout the rest of this talk. So in terms of evaluation of adrenal incidentaloma, I wanted to refer to a few set of different guidelines, which I will be referring to throughout this talk. The first is one of an NIH consensus statement on management of the incidentaloma from 2002. The next set of guidelines is from the American Association of Clinical Endocrinologists and the American Association of Endocrine Surgeons from 2009. The third is the American College of Radiology guidelines, which is a paper on the management of incidental adrenal masses from 2017. And lastly, to talk about the European Society of Endocrinology guidelines in collaboration with the European Network for the Study of Adrenal Tumors from 2016. So the first question to ask for evaluation of adrenal incidentalomas is it functioning? Most adrenal incidentalomas are non-functioning adenomas. However, the branch point is that hormonally hyperfunctioning adenomas will be managed surgically, and therefore it's important to evaluate for all 3 conditions, hypercortisolism or Cushing syndrome, pheochromocytoma, and lastly, aldosterone if the patient's hypertensive. In general, you might not need to test for the production of excess sex hormones unless there are obvious clinical stigmata of this. So then the next part of the evaluation, in addition to asking, is it functional, is this a benign lesion or is this a malignant lesion? So for example, but you could have a benign adenoma, or you could have a more concerning malignant lesion, such as metastatic disease and adrenal cortical carcinoma. And the slide lists on this slide common metastatic diseases that can present in the adrenal gland, including lung, melanoma, kidney, gastrointestinal, breast, and lymphoma. And then in terms of evaluation, radiology is key. And one question would come up, what are the imaging characteristics that we should consider? The two main ones are size and the appearance on imaging. So in terms of evaluation of adrenal incidentalomas with respect to size, oftentimes we hear of the 4 centimeter cutoff and or the 6 centimeter cutoff. So the NIH consensus from 2002 recommends that tumors over 6 centimeters should be treated surgically, and those that are less than 4 centimeters are generally monitored. For tumors between 4 to 6 centimeters, you may want to also take into other criteria when deciding to proceed to either monitor or proceed to adrenalectomy. The next consensus is from the American Association of Clinical Endocrinologists and American Association of Endocrine Surgeons, and they favor that adrenal masses with concerning radiographic characteristics and most lesions, which are over 4 centimeters, should be resected because of increased risk of adrenal cancer. And they have the quotes below. So 2% of lesions under 4 centimeter can be cancer, but it can be up to 25% for lesions which are over 6 centimeters. And one thing to note is if the lesion looks concerning, even though it's smaller than 4 centimeters, surgical resection should be considered, and also surgical resection should be considered if this is a functional lesion. In terms of imaging characteristics, imaging is key. So for a benign adenoma, they typically have homogeneous density and a smooth contour. On a non-contrast CT scan, it'll be less than 10 Hounsfield units. And what the diagnosis of an adenoma will rely on the presence of lipid in the adrenal lesion, and the fat in the lesion will result in low attenuation. However, there's always exceptions to the rule, and you can have a lipid-poor adenoma, and they may not have an attenuation value less than the 10 Hounsfield units, and they may be 20 to 40 Hounsfield units. And the other way to evaluate it is an adrenal protocol CT or a delayed contrast enhanced CT, where you would have rapid contrast washout, and 10 minutes after the administration of contrast, the washout should be greater than approximately 50%. The second most common adrenal lesion that you could potentially see are adrenal myolipomas. And they are made of adipose tissue and extramedullary hematopoietic tissue elements. On CT, they're often well circumscribed, round or elliptical, hypodense, and they can be heterogeneous. In terms of malignant imaging, one could have metastatic disease to the adrenal glands, and as with any metastatic or most metastatic lesions, they can be heterogeneous, have irregular margins, and in a large percentage of cases, they can be bilateral and have pretty significant variation in size of these lesions. Then the next potential thing that could be seen on imaging that would be concerning for malignancy is the adrenal cortical carcinoma. It's very rare, it has a poor prognosis, and oftentimes the way they will look on imaging is that they will be greater than 10 Hounsfield units on a non-contrast CT, and a lot of times it'll have an attenuation greater than 30 Hounsfield units. The vast majority, or the majority of adrenal cortical carcinomas are hormonally active. Oftentimes can present with high cortisol and virilization. However, in contrast, the adrenal cortical carcinomas that present just as a radiographic incidentaloma, those could often be non-functional because they're detected incidentally. So in terms of going back to our patient who we initially talked about at the earlier in this talk, this was the 65-year-old woman who had labs consistent with a non-functioning 13 millimeter adenoma. She had, as listed here, she had evaluation for Cushing's, pheochromocytoma, and hyperaldosteronism, and her evaluation was negative. And the values that she had are listed in further detail on this slide. So then the question comes up, do you need to repeat hormone testing? Yes, no, or yes? And how often do you need to repeat imaging? Do you need to repeat it never, or in 3 to 6 months and then annually? Or would you want to first review just to see if she has old imaging and compare it to prior imaging? So I'm going to talk about a couple of sets of different guidelines. The first is the American Association of Clinical Endocrinologists and American Association of Endocrine Surgeons. They have a set of guidelines for patients who do not fulfill the criteria for surgical resection. They recommend radiographic evaluation in about 3 to 6 months and then annually for 1 to 2 years. And they recommend pretty comprehensive hormonal evaluation at diagnosis and then annually. And in terms of surgical approaches, they would want you to consider surgery if there's a greater than 1 centimeter growth or if it turns out to be hormonally active. On contrast to the prior slide, the European Society of Endocrinology and European Network for the Study of Adrenal Tumor Guidelines have a less active surveillance protocol. They say that if the non-contrast CT is consistent with a benign mass, so it looks like an adenoma to less than 10 Hounsfield units, and the biochemical workup suggests that this is a non-functional lesion, additional surveillance is not needed unless there are new clinical signs of endocrine activity. So they have a slightly they have a different approach to the follow-up of adrenal incidentalomas. Then the next guidelines I wanted to talk about in terms of follow-up recommendation are from the American College of Radiology. They say that if they group it into masses which have either benign imaging features, which is presented on this slide, or less or more equivocal imaging features, which is presented on the following slide. So for masses with benign diagnostic imaging features, for example, if it looks like a myelopoma or a hemorrhage, you don't need additional workup or follow-up imaging. And they also suggest if the mass has a density of less than 10 Hounsfield units and it has certain features on MRI, which are outlined on this slide, it's most likely a lipid-rich adenoma and further imaging is not needed. Then on this, in this slide, they have broken into lesions which are not diagnostic. And they broke it into 2 groups, lesions which are 1 to 4 centimeters listed on the top, and lesions which are greater than 4 centimeters on the bottom. So for lesions between 1 to 4 centimeters in size, they want to base the algorithm on follow-up based on prior imaging studies the patient might have had and if there's a cancer history. So for example, if the lesion has been stable for a year, it's likely benign and additional imaging is not needed. They would consider an adrenal CT protocol in a year for 1 to 2 centimeter lesions. And for lesions which are most likely benign, if they're in the 2 to 4 centimeter category, you may want to consider a dedicated adrenal CT protocol. If the mass is without diagnostic features and it's over 4 centimeters, they would suggest surgical resection because of the possibility of that it could be an adrenal cortical carcinoma. And so in terms of why we have, in terms of these different guidelines, I just wanted to present I wanted to present one study. This study looked at hormonal activity of adrenal incidentalomas, and it consisted of 77 patients who had an incidentally discovered adrenal mass measuring between 1 to 6 centimeters. And they did hormone assessment at diagnosis, and they monitored these patients with hormone assessment along with imaging studies 12 months later, and then every 12 to 24 months with a median follow-up of approximately 60 months. And they identified 4 different groups. Group 1 had normal adrenal function in 49 out of 77 of the patients. 12 of the patients had constant autonomous subclinical cortisol hypersecretion. 12 of the patients had intermittent autonomous subclinical hypersecretion. But interestingly, highlighted in blue here, there were 4 patients who actually were later noted to have overt disease, 2 Cushing's and 2 pheochromocytomas, even though they had normal adrenal function at initial evaluation. So based on this, one might consider repeat surveillance or biochemical testing, even if the initial evaluation is negative. In terms of what went on with the imaging and what occurred with the imaging, 20 out of 77 of the patients had an increase in size of the adrenal lesion, and 10 of them of greater than half a centimeter, and 10 of these patients had an increase in size of over a centimeter. And of note, the ones who ultimately went on to be overt endocrine disease were the ones which had the largest growth over a centimeter in size. Then for the second part of my talk, I wanted to talk about adrenal hyperfunction and break it into the three main hormones: aldosterone, cortisol, and metanephrines. So first, primary hyperaldosteronism. So primary hyperaldosteronism is characterized by inappropriate cortical aldosterone production, and it can lead to hypertension, cardiovascular damage, sodium retention, decreased renin, and increased potassium excretion, and possibly hypokalemia, low potassium. On routine laboratory studies, patients may have a slightly high serum sodium, either upper normal or slightly above the reference range, hypokalemia, and metabolic alkalosis. Why is hyperaldo important? Some studies have suggested that there may be a higher cardiovascular morbidity and mortality compared to age and sex matched patients who have just essential hypertension and the same degree of elevated blood pressure. And there's a treatment. So you could either consider treating primary hyperaldosteronism with a mineralocorticoid receptor antagonist, or if indicated, a unilateral adrenalectomy, and that may improve the hypokalemia, blood pressure, decrease the number of medications for blood pressure the patient is taking, and lead to improved parameters of cardiac and renal function. In terms of the etiology of primary hyperaldosteronism, the two main causes, it can be either aldosterone producing adenoma, or you could have bilateral idiopathic hyperaldosteronism. Less commonly, it can be caused by adrenal cancers and inherited conditions such as familial hyperaldosteronism. In terms of how common, previously experts had, in terms of how common primary hyperaldosteronism can be, previously experts had mentioned that it could be less than 1% of patients with hypertension, and they assumed that the low potassium, the hypokalemia, was a gold standard for the diagnosis. However, that said prior thought process has shifted somewhat, and some cross-sectional and prospective studies report primary hyperaldosteronism in about up to 5% and maybe even up to 10% of hypertensive patients. And this has been both in a general setting and in a specialty setting. And in terms of the hypokalemia, only a minority of patients with primary hyperaldosteronism, perhaps between 9 to 37%, could have hypokalemia. So not all patients with primary hyperaldosteronism will have hypokalemia. I wanted to just show a study which focuses on how common the primary hyperaldosteronism can be. And this is a study of about 1,100 patients who have hypertension, and they wanted to look at the prevalence of primary aldosteronism in a newly diagnosed hypertensive patients. It was patients who were, the study consisted of patients who were referred to about 14 different hypertension centers, and there were 1,100 patients were enrolled, and approximately a fair high percentage, 4.8%, had an aldosterone producing adenoma, and 6% had idiopathic hyperaldosteronism. So a fairly high percentage of patients had the primary hyperaldosteronism who were newly diagnosed hypertensive patients. This study shows that a substantial proportion of the patients who have APA, which is the aldosterone producing adenoma in the middle graph here, and idiopathic hyperaldosteronism, which is on the right graph here, did not actually have hypokalemia. So in the middle section here, 48% did have hyperkalemia for the aldosterone producing adenoma patients, but that means 52% did not. And for the idiopathic hyperaldosteronism patients, 16.9% of the patients had hypokalemia. Then the next figure looked at the proportion of patients with primary hyperaldosteronism and looked at the percentage of patients who had hypokalemia. So this looked at the percentage of patients by the degree of hypertension who had the different conditions. So on the left bar here, these are the patients with normal blood pressure, and 92% were just primary hypertension. But on the right side, the patients with the most severe hypertension, a larger portion of them had either idiopathic hyperaldosteronism or had an aldosterone-producing adenoma. In terms of measuring the aldosterone to renin ratio, there's a protocol or a way of approach to doing this that's optimal. So you want to do it in the morning time. Partly you want to do it in the morning time because some aldosteronomas can have some diurnal variation. And you want to do it after the patient has been out of bed for a couple of hours and after they've been seated for about 5 to 15 minutes. One thing that you may also want to do is check a potassium and when you're collecting the aldosterone level, and also attempt to correct the hypokalemia. A low potassium can lead to decreased aldosterone secretion, which can then lead to a false negative test. And you would want to consider withdrawing agents that could have significant effect on the ratio for at least 4 weeks. The ones really are spironolactone, eplerenone, amiloride, and triamterene, and possibly the potassium wasting diuretics. And then kind of the next step after you measured, if the ratio is not diagnostic and you could use some medicines that have less interference, you may want to consider withdrawing those medications as well. And on this slide, the list includes the medicines which might have some, but not as a large impact on the renin aldosterone measurements. And on the bottom part, medications which have a lesser effect on the ratio, which you may want to consider having your patients on, can include slow-release verapamil, hydralazine, along with doxazosine and prazosin. And I put this slide up here as I think it's helpful to look at, and it looks at how will medicines affect aldosterone levels, how will medicines affect renin levels, and how would they affect the aldosterone-renin ratio, and whether they would affect it with a false positive or could it cause a false negative. So sometimes it's helpful to look at what the patient may be taking and seeing how those medicines could be impacting the results of the studies. In terms of interpreting the ratio, a low renin level or suppressed renin on a patient who's either on an ACE inhibitor or an angiotensin receptor blocker suggests hyperaldosteronism. And primary hyperaldosteronism should also be suspected when the renin is low and the aldosterone is increased greater than 15. Some studies and newer guidelines say maybe even greater than 10, you may want to start suspecting it. And the aldosterone renin ratio will be greater than 20. And then the next question is, who needs confirmatory testing? So the guidelines suggest they recommend confirmatory testing in patients with a positive ratio, and they undergo a confirmatory test to definitively confirm or exclude the diagnosis. And the ways you could do this are oral sodium loading, saline infusion, fluticortisone suppression, or a captive pull challenge. Typically what I do is the oral sodium loading if I think they can do so safely. If you do oral sodium loading, you need to make sure you're watching their potassium to make sure that's not being affected, and watch their blood pressure. And usually what I would do is give salt tablets on day 1 and 2, and then on day 3, they can do a 24-hour urine collection and aldosterone, 24-hour urine aldosterone measurement. The guidelines suggest that there may be no need for further confirmatory testing if the patient has spontaneous hypokalemia, low renin, and high aldosterone level. And I think this this slide kind of helps summarize some of the guidelines. And if someone has an adrenal CT and you're suspecting primary hyperaldosteronism, if surgery is desired, sometimes you may want to consider AVS, adrenal vein sampling. And if you find it's unilateral, then you can proceed with laparoscopic adrenalectomy. If the patient has really marked hyperaldo, they're young and have a positive CT, you may not necessarily need the AVS, but on the next slide, I'm going to show why it may be important and highlight the importance of AVS. So adrenal vein sampling can help differentiate between aldosterone-producing adenoma versus idiopathic hyperaldosteronism or bilateral hyperplasia. Imaging cannot imaging cannot reliably visualize a microadenoma or distinguish between a non-functional adrenal adenoma. So for example, on the left, in slide A or panel A, there's this is supposed to point to a right adrenal nodule, and then the left adrenal gland looks unremarkable on the imaging, this initial imaging. The patient then had adrenal vein sampling, and the lesion actually localized to the left side. And then the patient had the left adrenal gland removed, and the hypokalemia and hypertension was significantly improved after surgery. Even though the initial imaging pointed out to something on the right side, the adrenal vein sampling localized a left-sided lesion, and the patient proceeded to having a left-sided adrenalectomy. The second hormone to talk about is cortisol. So in terms of Cushing's syndrome, some of the signs and symptoms of Cushing's syndrome, common signs and symptoms can include decreased libido, obesity, plethora, round faces, menstrual changes, hirsutism, hypertension, lethargy, the dorsal fat pad, abnormal glucose tolerance. And on the right side listed are also some of the less common features that can be seen in Cushing's syndrome. In terms of the diagnosis of Cushing's syndrome, it can really be done in three possible ways. So you could either do a 24-hour urinary free cortisol, an overnight 1 milligram dexamethasone suppression study, or a late evening salivary cortisol. However, you do want to consider the caveats of each test. And I'm going to go through that on the next few slides because there's certain cases where one study might be better than another. So first, for late evening salivary cortisol, it might, since cortisol secretion varies with the time of the day, it may not be appropriate for shift workers or people who have a different sleep cycle. Then the overnight dexamethasone suppression test, it's conducted by taking 1 milligram of dexamethasone at 11 o'clock and having a cortisol test the next day at 8 a.m. And the cortisol, depending which cutoff you use, should be either less than 1.8 or less than 5.0 micrograms per deciliter. There can be some times when you have false positives. For example, a woman on birth control could have a false positive result because the estrogens are going to increase her cortisol binding globulin levels. You could also potentially have false negative if the patient is taking a medicine which can increase the clearance of dexamethasone. So sometimes I often also like to include a dexamethasone level when I am checking the cortisol level on the following day to ensure they took it and to ensure the levels are in a reasonable range for the dexamethasone as well. Other way to diagnose Cushing's is a urinary free cortisol. The advantages of it is that it is not affected by conditions and medicines that can alter cortisol binding globulin. Reasons for false positive urinary free cortisols can include high fluid intake. If patients have mild or more moderate to severe renal impairment, they could have a false negative urinary free cortisol. In terms of what to do for adrenal incidentalomas, since you will be seeing more adrenal incidentalomas as opposed to other potential etiologies of Cushing's, the urinary free cortisol does appear to be less sensitive compared to the 1 milligram dex suppression study or late evening salivary cortisol. In terms of the causes of Cushing's syndrome, it can either be ACTH dependent or ACTH independent. So ACTH dependent can either be Cushing's disease or ectopic ACTH syndrome. And for ACTH independent causes, it can include adrenal adenomas, adrenal carcinomas, and then these two less common conditions where you could have micronodular hyperplasia, where you can often have bilateral adrenal micronodule hyperplasia, or this one here where you can have macronodular hyperplasia bilaterally. And one important thing is to make sure that if you do suspect a patient could have Cushing's and they have an adrenal lesion, you really want to hone down on whether this is ACTH dependent or independent. So if you check an ACTH, a basal ACTH, and it's less than 5, it suggests ACTH independent disease. If it's 5 to 20, it's less definitive, but usually cortisol secretion is ACTH dependent. And if the basal ACTH is over 20, the cortisol secretion often or most likely is ACTH dependent. So for example, adrenal incidentalomas can be common. So suppose the patient has a cortisol level that's elevated, you suspect the patient has Cushing's, and you check a baseline ACTH and cortisol level, and their ACTH level is significantly elevated. It's possible they might have a pituitary cause of their Cushing's, and what you're noticing in the adrenal glands may not be the primary etiology of their hypercortisolism. And of note, in patients who have Cushing's disease or ectopic ACTH syndrome, they can develop ACTH-dependent bilateral macronodular hyperplasia due to long-term adrenal stimulation. Then I want to talk a little bit about this entity called subclinical Cushing's syndrome. What that is a subtle autonomous production of cortisol in a patient who does not have overt features of Cushing's syndrome. So they do not look Cushingoid, they don't have any symptoms. The diagnosis is made biochemically. And once again, the 1 milligram dexamethasone suppression study may be more sensitive than urinary free cortisol. And perhaps more than 5% of patients who have an adrenal incidentaloma might have the subclinical Cushing's syndrome. And in terms of patients who have this syndrome, many but not all studies found a higher prevalence of high blood pressure, obesity, insulin resistance, dyslipidemia, and osteoporosis. And the progression, however, to overt Cushing's syndrome is quite rare within 1 to 7 years of follow-up. And the European guidelines have a proposed entity. So they propose this term autonomous cortisol secretion for patients who don't have signs of overt Cushing's, but their serum cortisol levels after the 1 milligram of dexamethasone is still greater than 5 micrograms per deciliter. And they suggest the diagnosis of possible autonomous cortisol secretion if their post-dexamethasone cortisol is between 1.9 to 5.0 micrograms per deciliter. And with anything, they that is still being looked into and still being evaluated. Surgical treatment should be considered and an individualized approach in patients who have comorbidities which might be related to cortisol excess. And I think this slide helps distinguish the different categories. So you do on this top line is the 1 milligram dexamethasone suppression study. And then this breaks it out into the 3 groups of people. They suppress to less than 1.8. They are between 1.9 to 5.0 or greater than 5. So the 1.9 to 5.0 group is defined as possible autonomous secretion, and the greater than 5 is autonomous cortisol secretion. And when should you consider surgical removal, highlighted in this red box here? Rarely in the majority of cases, though possibly in the patients who have comorbid features related to autonomous cortisol secretion and suppressed to after the dex are greater than 5 on their cortisol reading. So this group right here, which I'm circling here. And then post-operatively, a couple of considerations. Patient's previous, post-op adrenalectomy, the excess cortisol secretion can lead to suppressed CRH and ACTH, so post-operative glucocorticoid therapy is needed. And one question that comes up is how much do you need to give them post-operatively? There are some different approaches, and I just wanted to put a quote in from the Endocrine Society guidelines with how to manage these patients. And they say that some practitioners prescribe supraphysiologic doses, such as hydrocort 20 milligrams 2 to 3 times a day in the immediate post-operative period. There's no controlled studies to show whether this minimizes glucocorticoid withdrawal syndrome. However, other clinicians would only use physiologic doses to avoid this continued excessive glucocorticoid exposure. So different approaches, and that could be considered post-operatively. And however, On this third bullet here, I want to point out that despite the use of physiologic glucocorticoid replacement, patients still may have glucocorticoid withdrawal, which can include symptoms such as anorexia, nausea, weight loss, fatigue, flu-like symptoms, or joint pains. For the third hormone, metanephrines, pheochromocytomas. So pheochromocytomas arise, as you know, from the adrenal medullary chromaffin cells that produce catecholamines. And paragangliomas are derived from extra-adrenal chromaffin cells of the sympathetic paravertebral ganglia, and they can occur in the thorax, abdomen, pelvis, or from the parasympathetic ganglia in the head or in the neck and the base of the skull. So symptoms of pheochromocytoma can include episodic or sustained hypertension. However, a subgroup of patients may not necessarily have hypertension. Other symptoms can include headaches, diaphoresis, palpitations, pallor, and tremor. In terms of the genetics, the genetics is the percentage of pheochromocytomas, which are genetic, is constantly increasing. Perhaps up 25% of pheochromocytomas may be genetic. However, that number is continuing to increase, and certain genetic disorders that can be associated with pheochromocytoma include multiple endocrine neoplasia type 2, neurofibromatosis, and von Hippel-Lindau. So in terms of a patient that I had seen recently in my clinic, he was a 53-year-old man who had about 4 to 6 months of abdominal pain. His past medical history includes hypertension for 4 to 5 years. He also has a history of kidney stones, arthritis, and back surgery. His only medication is losartan, and his exam is notable for significant hypertension, blood pressure 176/93. And then he had imaging studies, which was performed. He had a CT scan, which showed a 6 centimeter heterogeneously enhancing left adrenal mass. And he also had a follow-up MRI, which showed a lesion on the left adrenal gland, which is about 5.5 centimeters, and it was T2 heterogeneously bright. And the differential that this could include pheochromocytoma, adrenal cortical carcinoma, or a metastatic lesion. In terms of biochemical workup for pheochromocytoma, you can either do the plasma-free metanephrines or the 24-hour urinary metanephrines. The advantages of plasma-free metanephrines is that it has a higher sensitivity, though it can have a higher false positive, but you may want to consider obtaining this if you have a high clinical suspicion of a pheochromocytoma. In contrast, the 24-hour urinary metanephrines have a higher specificity, a higher false negative rate, so you may want to consider this if you have lower clinical suspicion. And with pheochromocytomas, usually the values of the hormone testing will be significantly elevated. So you'd expect to see a 4-fold elevation above the upper reference range would be strongly suggestive of pheochromocytoma, although a 1 to 4-fold value above the upper reference range is significant, but not necessarily diagnostic. And you also, just like with the hyperaldosteronism and evaluation of the aldosterone-renin ratio, you would want to consider the medications the patient may be taking. So I put this chart up here to illustrate that certain medications can affect either plasma or urine laboratory testing for pheochromocytoma. So you would want to go through the medication list to see what they may be taking. Another consideration is that acute illness can also increase some of these labs. So if it's checked when the patient is acutely ill in the hospital with something else, you may want to consider repeating it in an ambulatory setting once their acute illness has resolved. So going back to our patient who is the 53-year-old gentleman with the 5.5 centimeter left adrenal mass, who has significant hypertension. He had lab studies which were performed, and those showed very elevated free metanephrines and normetanephrines. So the next question in terms of getting them to surgery and managing their blood pressure, how should it be best managed? So management of high blood pressure is approached with alpha blockade followed by beta blockade. So options, you could consider non-specific alpha blockade with phenoxybenzamine. Disadvantages of this approach is it's expensive. You may need to get prior authorization, and the pharmacies might not have this actively on hand, so the patient couldn't just get it right away. Another approach is the selective alpha-1 blocking agents, for example, doxazosine, which is much more readily available and easier to obtain. And as a reminder, beta blockers should never be started first, since unopposed alpha-mediated vasoconstriction might lead to hypertensive crisis. And if the blood pressure is still not optimally controlled on the alpha agents, you could also consider potentially adding calcium channel blockers as well. And ones to consider can include amlodipine and nifedipine. While you are getting them ready for surgery, you want to encourage a high sodium diet and fluid intake to reverse any of the catecholamine-induced blood volume contraction. And I just included this as a slide to include or to review some of the perioperative medical management. I like the slide because it kind of just helps think about the starting doses you may want to consider and up to the maximum doses that you could potentially consider. And the top is the alpha blockade regimens. The second one is the calcium channel blockers, which you could add on when the blood pressure is not adequately controlled by the alpha blockade. And then the third one is the beta blockers, which you would add on after a few days of starting the alpha blockers. Then I also put this on to include certain medicines you want to make sure the patient is not taking. So these are the medicines that can include, that could potentially precipitate a pheochromocytoma crisis and hypertensive crisis. So avoiding these medications in patients preoperatively. And last part of my talk, I wanted to briefly talk about adrenal insufficiency. First, primary, and second, and afterwards, secondary and tertiary adrenal insufficiency. So for primary adrenal insufficiency, symptoms can include fatigue, anorexia, nausea, vomiting, stomach pain, salt craving, dizziness. Patients can also present with skin loss, skin hyperpigmentation, hypotension, and typically their labs would show the following, noted here: low sodium, high potassium, possibly anemia, and high eosinophils. In terms of the diagnosis of adrenal insufficiency, you could consider first checking at morning cortisol. And if the morning cortisol is less than 3, it's highly suggestive of adrenal insufficiency. And if it's greater than 15, adrenal insufficiency is highly unlikely. Another approach to doing it is a 250 microgram cosentropin stimulation study. And with that, you would check a baseline cortisol and give the cosentropin IV or IM, and then check cortisol levels at 30 or 60 minutes. And a value of over 18 excludes adrenal insufficiency. The one caveat, and this is more for pituitary patients, is if they had new onset pituitary ACTH deficiency, they might still have a normal stimulation study since their adrenal studies, their adrenal glands have not undergone atrophy yet. And in terms of management of adrenal insufficiency, you would want to consider between 15 to 25 milligrams a day of hydrocortisone in 2 to 3 divided oral doses per day. And you monitor their dosing based on their clinical assessment. And for mineralocorticoids, you would want to consider fludrocortisone at a dose of 0.05 to 0.1 milligrams per daily, and typical doses are between 0.05 to 0.2 milligrams. And this is particularly relevant in the patients who've had adrenal Cushing surgery. So you want to kind of go through, what they may need to do post-operatively, what they may need to watch out for. So in terms of treatment for primary adrenal insufficiency, you would want to make sure they have a medical alert bracelet, have a glucocorticoid injection kit such as Solu-Cortef for emergency use, and you would want to give them some education for what to do. So in a minor illness, I often increase their dose of glucocorticoids to 2 to 3 times normal for about 3 days. If they're sick, they can't keep down foods. If they have nausea, vomiting, then they should take their emergency glucocorticoid injection kit and then seek more urgent medical attention. And then the last part of the talk I wanted to discuss was secondary and tertiary adrenal insufficiency. So in secondary adrenal insufficiency, there's pituitary disease that impairs the release of ACTH. In tertiary, there is interference or decreased CRH production from the hypothalamus. And the exogenous steroids that a patient may be taking might exert negative feedback control on this HPA axis by suppressing CRH and therefore by suppressing ACTH secretion. A few slides ago, I put up the signs and symptoms of primary adrenal insufficiency, and I didn't repeat them all here, but I just wanted to contrast how central or secondary adrenal insufficiency is different. So first, the GI symptoms tend to be less common. In terms of signs, the patient would not have hyperpigmentation. And then in terms of labs, you would have hyponatremia, but you would not have hyperkalemia since the aldosterone is still intact, and hypoglycemia is potentially more common. And I just wanted to give a clinical case about a potential patient who might be presenting to your clinic for a surgery, and whether the question would come up, do they need to have steroids around the time of surgery? How do you manage their steroids perioperatively? So for example, this is an example of a 68-year-old woman who's been on 8 milligrams of prednisone for the last 5 months for more of a pulmonary or rheumatology indication, but you guys are she's planning to have some type of urologic surgery. So the question that comes up is, what is the risk of secondary adrenal insufficiency, and does she need steroids preoperatively? Does she need anything around the time of surgery? So I took this reference from UpToDate, which I think is a pretty helpful way of thinking of things. And they kind of divided it into 3 categories. The first 2 on this slide, and the next slide will show the third one. You probably will be okay and will not have a suppressed hypothalamic pituitary adrenal axis if you're on in any of these categories. If they've only been on steroids for less than 3 weeks, they're on less than 5 milligrams of prednisone or its equivalent, or less than 10 milligrams of prednisone or its equivalent every other day. In terms of the intermediate group, where you're a little bit less clear, patients who've been on between 5 to 20 milligrams of prednisone can have a large variability in their hypothalamic pituitary adrenal axis. So if you can do it, you may want to consider pre-op evaluation before their surgery to see if they need additional steroids. But if they're going to have an emergency surgery, you may want to consider empiric perioperative glucocorticoid coverage. You will likely have a suppressed HPA axis if they've been on more than 20 milligrams for over 3 weeks. And also this group here, if they clinically look Cushingoid to you, even if they're on lower doses, if they look Cushingoid, you may want to assume that they have a suppressed HPA axis. Some studies show that the suppression of the HPA axis could take up to 1 year to recover. And of note, not everyone fits exactly these slides, or the last slide and this slide. If patients are on certain medicines that can affect the cytochrome P450 pathway, such as ritonavir or azole antifungals, they may have a more pronounced suppression of the HPA axis. So for example, if a patient's on ritonavir plus even inhaled steroid, they may still have some suppression. So be cautious and prudent if the patient's taking any of these medicines that couldn't affect this pathway. And then I just want to conclude by one more study looking at adrenal insufficiency in patients who are on steroids. This is a meta-analysis, which is looking at the risk of adrenal insufficiency after different steroids in different conditions. However, the caveats are these studies displayed a lot of heterogeneity in the type of steroid used, their patient's underlying condition, the treatment dose and duration, and route. So there's some limitations of this, and they had to include studies which have some bias because there are only a few articles where a low level of bias was available. So this is looking at the adrenal insufficiency risk by administration form. So Here, oral steroids up to 50% could have some degree of adrenal insufficiency, though even some of the patients receiving inhaled, topical, or nasal were at risk for adrenal insufficiency. Interestingly, the ones who got a intra-articular steroid were also at risk for adrenal insufficiency. And then this is looking at the risk of adrenal insufficiency by the treatment dose and the duration. So kind of as we would expect intuitively, the first three bars are people short, medium, or long-term use of steroids. The longer they've been on them, the higher the risk. And in the bottom three, low, medium, and high dose, the larger the dose, the higher the risk of adrenal insufficiency. So in conclusion, I wanted to kind of go through three things on my talk: adrenal incidentalomas. The majority of adrenal incidentalomas are non-functioning, but it's important to check if it's malignant or functional. For adrenal hyperfunction, the three hormones of most importance include the aldosterone, cortisol, and epinephrine. Primary hyperaldo can be common, perhaps in over 5% of hypertensive patients, and it's associated with higher cardiovascular morbidity. And when you're screening for adrenal hyperfunction, you want to consider potentially the medicines that could interfere with the measurements. And then for adrenal insufficiency, patient education is very important, and you also want to consider the risk for adrenal insufficiency after corticosteroid use and what you should do perioperatively in those patients, as well as after Cushing's surgery. Thank you.